Hello, good morning everyone, and welcome to this last clinical contact session of this course, Clinical Management of HIV. So this week, towards the end of the sessions, there are some announcements which I'll make, and uh, and we'll try to address if there are any remaining questions or concern regarding this course. So this week the topic was management of STDs, that is sexual transmitted diseases, in HIV-infected patients. So as usual, there were two lectures conducted by UW faculty on STIs in context of HIV, which were done in two parts, part 1 and 2. Part 1 was STIs in male and part 2 was STIs in female. In these two parts, as you can see here, the topic says management of STDs, and the lectures, if you see the title of lectures, is STIs. So there is definitely a difference between STDs and STIs. We will come to that. So what I have done for this clinical contact session is, because it is very unfair to cover, and we cannot do actually, this topic is so huge, this is a separate, this can be a separate course altogether. So what I've done is I'm not referring to all the slides which were presented by University of Washington faculty in these two lectures. So we'll directly come to the STIs or management of STIs in Indian scenario. So it will be important for you all to go through two lectures on the Canvas website, so that it will be easier for you to solve the quizzes. I hope all of you are solving quizzes regularly, and also homework assignments. We'll talk about quizzes and remaining homework assignments towards the end, because this is the last session, as I mentioned before. So let's start with this session. I hope all of you are able to hear me properly. So if there is any disturbance, you can send a message. As Praveen informed in the WhatsApp group, he is not with us today. So I have logged in directly. I may not be able to address the technical issues immediately. So if you have any concern, you can type in the chat box, but let's see how I'll be able to address that concern. So please bear with me on this. So let's start with the introductory slides. In this 1 hour or 1.5 hours, whatever time we have, as I mentioned, it will not be possible to cover all the STIs and STDs discussed during the session done by UW faculty. So we'll be focusing on some data regarding STIs as per Indian scenario, and also we'll talk about the national program, how NACO addresses STIs, and how NRHM, what is available under NRHM, that is National Rural Health Mission. And we'll try to understand the STI as a cofactor in HIV transmission, how HIV transmission is affected by presence or absence of STIs. And we'll see where STIs are placed under WHO clinical staging. Is there any detail for that? That we'll try to again relook, because we have already seen WHO clinical staging in one of the sessions before. We'll try to enlist the common approaches, management approaches for management of STIs, and with special emphasis on syndromic management, because that is the one which we follow in India. As I mentioned, there is a difference between STD and STI. STI is a preferred term over STDs, which was used earlier. That is an old term actually, because it encompasses both symptomatic and asymptomatic infections. Because STD, if you say, that is only symptomatic STI, but when you say STI, it will include both symptomatic and asymptomatic infections. So some of the STIs are silent, like chlamydia, pelvic inflammatory diseases, and if you refer to terms only STD, those silent STIs will be missed, and that is why we'll be using STI in place of STDs. We have seen this kind of thing before, but not in this format. As we know that we have a concentrated epidemic of HIV infection in this country. which is concentrated among key groups which are considered to be high risk groups. So there are three main groups which are being intervened by national program. There is female sex workers, men who have sex with men, injection drug users, or nowadays they are called as PWID, that is people who inject drugs, or and transgender population. Now there is a risk of transmission of HIV from this high risk group to general population, which is mentioned here, which is considered to be low risk of HIV, because the major mode of transmission is sexual route of transmission. So a group which connects these two groups is called as a bridge population. Bridge population includes mainly migrant workers and truckers, and of course there is a risk to newborn children as well, because from general population or from the mothers who are HIV positive or ANC or pregnant women, HIV can get transmitted to the newborn children as well. So this is how we define as a define high risk groups, and the transmission from high risk group, or the risk of transmission from high risk groups or key risk groups to general population. This is important to understand this link here as well in context of STI, because both HIV and STI, if you see the mode of transmission and spread, they are similar. So what is the interrelationship or relationship between STI and HIV? There are multiple factors, if you can see here in this slide. And there are behavioral factors, epidemiologic relationships they have, and also immunological. So in behavior, if you see STI and HIV, as name suggests, these are the sexually transmitted infection. And as I mentioned before, for HIV, the main mode of transmission, we have seen in the earlier slides that more than 85%, almost now more than 89% HIV acquisition which has happened is through sexual route of transmission. And so, and also epidemiologically, if you see the population with high rates of STI, they show disproportionately high rate of sexually transmitted HIV infection. We will see the reasons and factors in detail in the future slides. The STI facilitate sexual acquisition of HIV and transmission. So that relationship also we'll see in details. So HIV infection, as I mentioned, is predominantly sexually transmitted in India. That is about 89% of HIV infections have happened through sexual transmission. STI, they amplify HIV transmission. Presence of STI increases risk of HIV transmission. That is because of multiple factors. We'll try to address those cofactors also. Because if you see STI in general, they amplify HIV transmission 3 to 22 folds depending on the presence of inflammatory or ulcerative STI. We'll come to know again more about STIs. There are multiple types. Some of them are inflammatory types, some of them are ulcerative types. In number wise, if you see, NACO illustrates that the predominant mode of HIV transmission is sexual. We have seen that is 89% almost. And cofactors, if you see for HIV transmission, if there is loss of epithelial integrity, which results in disruption of surface or mucosal epithelium, which provides an entry route for STI or HIV pathogen. So in intact mucosa, if it is there, there is again less risk of HIV or STI transmission or introduction into the body. But if there is any disruption in epithelial integrity, it will facilitate the entry of STI or HIV infection. And also there is recruitment and activation of inflammatory or CD4 cells. If it is there, it will increase the susceptibility of HIV infection, as does immune dysregulation in the host. STIs in HIV can increase the viral load. We'll see how it increases. And a higher viral load, if it is there, that it increases HIV transmission risk to others. We have seen this before. So this is what we tried to see in the previous slides. We have a core group here, which includes this population of female sex workers, MSM, and people who inject drugs, bridge population, and general population. So HIV is, as we said, 89% of HIV transmission is through sexual route, and STIs, they increase the transmission risk by 4 to of HIV by 4 to 10 times. It depends on which type of STI it is. Obviously, if it is ulcerative STI, risk of transmission will be more and more. So if you wish to achieve zero transmission of HIV, we cannot afford to ignore STIs. So there is a synergy between both, and also it is also a public health problem. So STIs adversely impact the reproductive health of women, or actually it affects the reproductive health as a whole entirely, but especially for women, because see, reproductive tract infections usually including STI, they present a huge burden of disease and adversely impact the reproductive health of the people. So if they cause suffering for both men and women around the world, but their consequences are far more devastating and widespread among women than in men. Unfortunately, the exact data on STI prevalence in India, especially in general population, is lacking. As per the recent STI prevalence study, which was done in 2003, it is not recent, but last it was 2003. Over 6% of adult population in the country suffers from STI, and most regions of the country show relatively high levels of STIs. The estimates also indicate that 40% of women have RTI, or reproductive tract infection, or STIs at any given point of time, but only 1% complete their full treatment in both partners. So it is well known that the risk of acquiring HIV infection increases manifold in people with current or prior STIs. STIs are linked to HIV transmission as common sexual behavior, but put person at risk of HIV infection, which directly increases the chances of acquiring HIV as well. Emergence of HIV and identification of STI as a cofactor have further lent the sense of urgency for formulating special program for this purpose, which we already are in. So you have seen this figure before also when we tried to discuss these three groups in our very first presentation, where we discussed the epidemiology as well. Here, as I mentioned, the ANC is a marker for general population, while migrant and truckers are bridge, and these four populations are considered to be high risk groups. So the prevalence of HIV, as I mentioned, it is a concentrated epidemic. So in female sex workers and MSM, in these high risk group, prevalence was high. So but over a period of time, if you refer back to those figures early in 2000, even in 2007 or 8, if you see, the national prevalence among female sex workers was as high as 5.06% in 2007, and most of the state they were having high prevalence, but again there were many interventions which were done, because of which the prevalence has reduced. If you see now, the prevalence is around 2.4%. And similarly, there is a decline which has happened in prevalence of HIV in MSM also, from as high as 7.4% in 2007, and now if you see in MSM, the prevalence has reduced to near 4%. There are some population where it is static, like IDU. If you see, there is a static prevalence of HIV infection, and also in transgender is again a group where it is worried that prevalence is not reducing. Someone is not able to see the video, or is it the problem with others also, or? Okay, we'll proceed further. So interaction between STI and HIV. Okay, thank you, Nazir. So the factors that affect STI transmission, as I mentioned before, there are multiple factors which we can mention under this. There are like efficiency of transmission, that is, for example, mode of transmission. Like if we talk about sexual route of transmission, we know that vaginal intercourse is less likely to transmit than the rectal intercourse, where the risk of transmission will be higher. Then also it is dependent on duration of infectiousness. If the duration of infectiousness of the person who has STI is more, then risk of transmission will obviously be more. And number of partners or a number of sexual acts also will decide whether the STI transmission happens quickly or not. So the probability of efficiency, if you see, of sexual transmission of HIV, it varies a lot. We have seen this in the risk of sexual transmission of HIV before in the form of table, if you remember. That is, it is 0.1 to 10%. That is 1 in 700 to 1 in 3000 sexual act, there will be transmission of one HIV infection. It depends on, again, nature of sexual act, varying efficiencies of transmission and other things. Then sexual behaviors that increases risk of acquiring HIV also increase risk of acquiring STIs. Biological factors that could increase risk of HIV transmission, if we talk about them, then infectiousness of host is increased with multiple factors, like if host has suppose high viral load, infectiousness increases, which is present, as you all know, that it is present in acute HIV infection as well as in more advanced HIV or untreated HIV infection. Then again infectiousness increases if there is a presence of genital tract changes, for example bacterial vaginosis or other STIs. Infectiousness is more if there is systemic co-infection, for example tuberculosis, or presence of again blood during sexual contact, like performing sexual contact during menstrual period of women. Then also if there is any like if the women are breastfeeding, again that will be another added biological factor for transmission of HIV. Gender wise, if you see, men and women differ. Women are more biologically prone to HIV than men because of increased mucosal surface area of vagina and reproductive tract, because of which pooling of semen happens. So there is a longer point or time of contact between the infected fluid with the vaginal epithelium. Then presence of genital ulcers or other STIs will again increase the risk. Then vaginal thinning also happens due to menopause or other use of like progestin or other contraceptives. Then immature genital tract of young women also, or young girls, that also is one of the factors which can increase the risk of HIV on STI transmission in women. So this figure will show the interaction between STI and HIV. If you can see here, STI will increase the risk of transmission of HIV and also increases the progression to the clinical disease. High risk sexual behavior will have the risk of both STI and HIV. And HIV, as we know, that it will impair the immune system, and which can cause altered frequency, and the natural history and susceptibility of STI will increase because of the low immune system. So that is how it works, and that is how it demonstrates the interaction between STI and HIV infection. Now if you can see these two figures, this is actually prediction of the efficiency of HIV transmission according to HIV burden in the genital tract, because genital tract which have genital secretions having high burden of HIV virus. If you see the figure A, it is probability of male to female HIV transmission per coital act as a function of HIV disease stage in index case. Transmission probabilities are shown for each stage of disease. Yellow is expected distribution of viral burden in semen among men over time, and red is theoretical effect of biological intervention designed to reduce the viral excretion. and the dotted line or dashed line is a potential threshold for HIV transmission. If you see figure B, it is determinant of HIV transmission probability, that is acute HIV infection, sexually transmitted infection, so that will determine the probability of transmission of HIV. So if you see an example here in the table, if there is no gonorrhea, HIV genital viral load will be 19%. If there is presence of gonorrhea here, that is pre-treatment, 44% of genital viral load. And if you just treat gonorrhea, we have not treated HIV here, just treat gonorrhea, post-treatment if you see it is 21%. So it is as good as no gonorrhea. That is viral load of HIV will be similar to the time when there was no gonorrhea. So urethral HIV DNA more than doubled when there was also the presence of STI, that is gonorrhea. And however, the treatment has cut the urethral HIV DNA in half, almost same as those without STIs. Here is a question: what is the most commonly used approach to treat STI now and why? At least we can say which is the most common approach which is used in India, though there are multiple approaches as I mentioned before. So as rightly answered by Parvinder, it is syndromic management. So syndromic management is the most widely and commonly used mode to address all STI and treat STIs. So there are multiple approaches, as I mentioned. There can be etiological approach, as the name suggests. It is again addressing the etiology or determine the cause of STI, for which obviously we'll have to know which kind of STI we are dealing with. Then clinical diagnosis will have to be made, syndromic approach and presumptive approach. So in etiological approach, it stresses the identification of organism, which is a causative organism, and treating the specific etiology which is identified. Problem with this approach mainly include that it needs the expensive laboratory support, for example dark field microscopy and other things which are not cheap. Also it needs sophisticated tests, for example chlamydia diagnosis, it will need again specific tests. Then the delay in initiation of treatment, because until unless you receive the results of investigation you will not be able to start the treatment. Then loss of follow-up because of the longer duration of the whole process. Then interpretation of results will be difficult because again you don't have very well established labs. Again, if you want to treat the partner, it is difficult to ensure whether partner received treatment or not. So there are again this approach of etiology, that is etiological approach. There are again many issues related to that. If you see the clinical approach, it focuses on clinical experience of the treating physician. For example, suppose I am a treating physician, I have treated multiple cases of STIs before. It depends on my again decision to treat the STI or not. So it is again experience based. The diagnosis will be experience based, again treatment will be experience based. Studies have documented the unreliability of this kind of approach. In studies which was done again in abroad, not in India, only 30% of the patients with chancroid and 10% of the patients with mixed infections were identified correctly with this approach of treatment. Clinical approach, if we see, it gives treatment to all possible STIs that cause the syndrome based on epidemiological and laboratory data. So this is a simple, easy to follow method which can be practiced by community health workers. Patients are treated at first visit. Minimal equipment or lab support is necessary for this kind of approach. It is effective in presence of mixed infection also because you are giving common treatment for all those mixed infections. Then presence of STI complicates or presence of STI complication and other conditions not included in the flowchart, they necessitate the referral for STI, because if you are managing or if you are treating patients with syndromic approach and if something is not there or if there is any complication, then we should know when to refer patients to the specialists. And the last approach is presumptive, which aims to treat asymptomatic STI with high risk groups. For example, in a community, suppose there is a prevalence of a particular STI which is very high, then for a public health, from a public health perspective, interventions which benefit a group of community level are essential for controlling STIs. So syndromic case management, it has again like the name suggests, in the management of this, we see specific syndrome, and the diseases which can cause that common syndrome are all treated together. So we give medicines for that. Follow-up is ensured that we ask clients to return in 7 days if symptoms persist. We also focus on partner notification and partner treatment in this. Then we rule out other STIs if there are there. Also, we offer voluntary HIV testing and counseling. Counseling and education regarding safe sex, risk reduction and behavior modification is given, and also we promote condom usage in this mode. In this mode. So, as it was mentioned in both the lectures done by UW faculty, there were two. We can divide all these STIs and RTIs in two main groups, or syndromes in two main groups basically. Syndromes which happen in men, and syndromes which happen in women. So the common syndromes which are enlisted here, and the symptoms of those syndromes, we need to remember these, like urethral discharge, genital ulcer, inguinal bubo or inguinal bubo syndrome, then painful scrotal swelling, ARD, that is anorectal discharge, gonococcal pharyngitis, and genital skin conditions. So these are all symptoms which may be present while you observe the whole syndrome as such, like this, and these are the common infection which can cause these syndromes. So instead of remembering treatment for each and individual diseases or infections, and they have been clubbed in based on the syndrome they cause. So each and every infection and disease can cause symptoms of urethral discharge. For example, if you take example of gonorrhea, chlamydia, trichomoniasis, they can cause urethral discharge. So syndrome we define as urethral discharge syndrome. So similarly, chancroid, syphilis, and genital herpes, they can cause similar symptoms like genital ulcers. Obviously, if you ask symptoms, in addition to genital ulcers, there can be more symptoms like pain, for example. There can be more symptoms, but genital ulcer will be one syndrome which we are interested in as far as syndromic management of STI is concerned. Is the video and audio clear to others? Okay. So similarly, there are other syndromes, and these are the other organisms which can cause those syndromes in men, and the same way we can see in women. There are syndromes like vaginal discharge, cervical discharge syndrome, lower abdominal pain, genital ulcer syndrome, anorectal discharge, gonococcal pharyngitis, and genital skin conditions. So these are multiple organisms. If you see, for example, cervical discharge, which is again difficult to differentiate from vaginal discharge sometimes, because symptoms will be same. There will be poor vaginal discharge. And organisms, if you see here, for cervical discharge, gonorrhea, chlamydia, trichomoniasis, herpes simplex. For vaginal discharge, it can be again trichomoniasis, candida, bacterial vaginosis, etc. Though it can be again differentiated, we do cervical tenderness test, and there are other tests which are available. So so there are again multiple clinical methods because of to differentiate between these two. But from outside, if we see the symptoms, it will be vaginal discharge. So, but syndrome, when we define, it will be either vaginal discharge or cervical discharge. So similarly, other organisms will cause these syndromes, and also the symptoms will be accordingly present or absent. So all these diseases have been grouped, and all these infections have been grouped based on the symptoms they produce and based on the syndrome which happens because of all these infections. So The major advantage here is you need not remember each and every disease and infection or STI infection to again remember their investigations and tests which will identify them and what is the again the clinical presentation of those things. We can just remember the syndrome and the organism which can cause those syndrome. Even if suppose you don't remember the organism, and if you remember the syndrome, you can treat those STIs effectively. So that is how syndromic case management helps in identification and also management of STIs. So we have already seen the advantages and disadvantages of syndromic case management. Just as a summary, I'll just mention the advantages are many. No laboratory test is required. It will reduce the cost of oral management. It works well with urethral discharge and genital ulcers. Simple to use, can be used at all levels of health system. It promotes standardization and also it facilitates the training of the staff. The main disadvantages of syndromic management is mainly many STIs are asymptomatic. So if there is no symptom, you will miss those. Then vaginal discharge is not necessarily the result of an STI. You all know, because of general bad hygiene also, or even there can be physiological vaginal discharge. Then overuse of drugs, for example, because we are treating syndromes, we sometimes land up in using these drugs more. So it will increase the cost of it, and also the side effects and resistance problems may be there. Then there can be lack of acceptance by clinicians who are, again, like I mentioned before, are experienced in management of STI. They may not like to use this thing. In one of the studies I just mentioned, an attempt was made to identify pathogens from individual with STI syndrome using standard microbiological techniques. The result of this study found that STD could be diagnosed in laboratory only in case of 30% males and 40% of females having some STI syndrome. So there are again multiple studies carried out in India, like for example in Tamil Nadu, where only 10.7% of the women were diagnosed having discharge. In another study conducted in Gujarat, the positivity was in 47.5%. So again, there, like I mentioned, we can look at the advantages of the overall advantages of management of STI through this method. So it will be fast, patient will be diagnosed early and treated in one visit. Most of it is like a single dose kit. It is relatively inexpensive if you consider the cost of diagnosis of this STI through other methods. No need of patient to wait for lab results. All possible STIs causing common symptoms and signs are treated together. It is scientifically proven, as I mentioned some of the studies before. Easy to learn and practice and easy to train people on. Easily added into the, again, all level of healthcare system, including primary healthcare system, can be implemented by all healthcare workers and facilitates the standardization of regimen. As I mentioned, again, it is over treatment. Sometimes cost will increase, and also resistance of to drugs might happen. So syndromes, we have mentioned this before. Syndromic approach uses flowcharts to identify causes of 7 common syndromes: urethral discharge, burning micturition, genital ulcer, vaginal discharge, scrotal swelling, lower abdominal pain, inguinal BIBO, oral and anal STIs. We'll try to see these one by one, and we'll try to just see the clinical background also. If you can see here the clinical presentation, it is nothing but a urethral discharge. So it is a 25 years old male presented with a history of unprotected sex a week before presenting with complaints of purulent urethral discharge. Now the way we can approach this patient is, as we can define this as a urethral discharge syndrome. So since there is a visible purulent discharge, we will treat this patient for gonorrhea and chlamydia as per the treatment chart. If you can see in this gray box here, it has been mentioned as kit 1. So these kits are again pre-prepared kits which will have tablet azithromycin 1 gram OD single dose plus cefixime 400 milligram OD, that is single dose. So it is a single dose kit which is given to a patient who presents with the urethral discharge. Complication of this urethral discharge can be again epididymitis, periurethral abscess, urethral stricture, prostatitis, gonococcal arthritis, etc. Next is cervical discharge syndrome or cervicitis. So we already saw the epidemiology, or we already saw the causes which result in cervical discharge or endocervical discharge. So here, if you can see in this picture also, there is yellowish discharge with usually it is with bad odor. Nature and type of discharge, if we see, it's again quantity, color, odor is noted. It usually burns. Again burning while micturition, and there will be increased frequency of micturition. So risk factors for cervical discharge, it includes younger women or who are again younger than 21 years of age, unmarried, again multiple, those who have multiple sex partners or last sexual partner in last 3 months. And also if suppose partner has sexually transmitted infection, again depends on usage of condom in the partner. So again for this syndrome, that is cervical discharge syndrome, same kit which we saw for urethral discharge, that is kit 1 is used, which has tablet azithromycin and cefixime. Next is painful scrotal swelling, as you can see in this picture also. Swelling and pain in the scrotal region may present with pain or burning micturiation also. There can be systemic symptoms like malaise and fever, and also there can be a history of urethral discharge in these patients. So the possible epidemiological or the possible etiological agents for this type of presentation can be gonorrhea and chlamydia. So we treat for both these infection, and both these infection can be treated with the same drugs, that is azithromycin and cefixime. So we use again kit 1 for this kind of syndrome as well. There are other infectious causes of scrotal swelling also which should be noted. For example, tuberculosis, filariasis, coliform and pseudomonas can also cause scrotal swelling. Even mumps can cause scrotal swelling. It can also be there because of trauma, hernia, hydrocele, and other causes of non-infectious scrotal swellings. Next syndrome is vaginal discharge syndrome. As name mentioned, it will be a frank again vaginal discharge which is seen, which is cheesy white. Nature and type of discharge will be again quantity, color, and odor is noted. Most commonly it is itchy, and there will be itching around the genital area. So as most common causes will be because of the fungal infections, it will be treated with antifungals. For example, for this we use kit 2, and kit 2 it contains secnidazole 2 gram OD single dose, in addition to fluconazole, that is 150 milligram OD, again it is a single dose. Next is genital ulcer, that is non-herpetic. There is a difference between herpetic and non-herpetic ulcers. Main difference is again the recurrent episodes in herpetic, while non-herpetic will be a single or multiple but painless ulcers, and herpetic ulcers will be more painful ulcer. We'll see in the next slides. So in genital ulcer which is non-herpetic, which will be typically seen like a genital ulcer, a single or multiple, painful or painless. Burning sensation in the genital area, burning sensation in the sometimes in the urine also. Then enlarged lymph nodes, that is regional lymph nodes, will be enlarged. So it can be caused by, for example, it can be there in syphilis, which is caused by Treponema pallidum. Herpes simplex also causes genital ulcer. We'll see in the next slide, that is herpetic genital ulcer. In addition to this, Haemophilus ducreyi, which causes chancroid, also can cause genital ulcer. Then granuloma inguinale caused by K. granulomatis. Then chlamydia trachomatis, also which causes LGV, that is lymphogranuloma venereum, can cause genital ulcer. So an assessment of the risk status will help in making diagnosis if you want to make. And syphilis chancre is usually single painless ulcer with induration, though atypical presentation will be common in HIV. Multiple chancres may be present, and also onset of lesion is after a sexual exposure. If there is no suspicion of herpes, then the treatment should cover for herpes and chancroid also. In herpetic genital ulcer, there will be typical eruptions like this of vesicle, painful, multiple genital ulcer, burning sensation in genital area. Again, there will be recurrence, which is very common. Usually there will be two types of herpes simplex viruses, type 1 and type 2. Usually genital herpes is caused by type 2 herpes simplex virus. The treatment for, again, recurrent herpes simplex or genital herpes is acyclovir 400 mg 3 times a day, for which we use kit 5, which has this acyclovir 400 mg, which is again available for 7 days in kit 5. Next is lower abdominal pain. So here, especially in women, it is they complain with the lower abdominal pain. Sometimes it is very low aching or dull pain. They may present with fever, vaginal discharge, menstrual irregularities like heavy irregular vaginal bleeding, dysmenorrheas, dyspareunias, that is pain during menses, pain during sexual activity, and lower back pain, cervical motion tenderness, like I mentioned before. If you again on PV examination, if you hold the mouth of cervix and you try to move, there will be tenderness present. So that is called a cervical motion tenderness, and that is how it is diagnosed and differentiated from vaginal discharge syndrome. So if this is the case, which I'm sure many of you might have seen this, we use kit 6 for this, which has cefixime 400 mg single dose, metronidazole 400 mg BD for 14 days, plus doxycycline 100 mg BD for 14 days. Next is inguinal bubo syndrome, where you will see swelling in the inguinal region, which may be painful swelling, if you can see it here. Then presents preceding history of genital ulcer or discharge may be present. There can be systemic symptoms like malaise and fever. If you see this, then we use kit 7 supplied by NACO again in Suraksha clinics, which has doxycycline 100 mg, which is used for 21 days, and tablet azithromycin 1 gram, which is used as a single dose. A couple of case studies we will see. This is suppose 23 years old female, HIV positive, commercial sex worker, present with altered sensorium and delusions. So in STIs, usually we didn't think of altered sensorium delusion, whether it can be caused by STI. Lab investigation, it revealed that blood for VDRL is reactive in 64 delusions, and CSF VDRL is reactive, and WBC in CSF, which will result, the result was acellular. What is the, what is this which we are dealing with here in this slide? Obviously here it is, as the name suggests, we are dealing with the neurosyphilis. So in cases which show neurosyphilis, they usually occur early, more severely cutaneous lesion if they are there, and alteration in duration and response to therapy. There is accelerated disease progression if it is a presentation like this. Natural course of syphilis may be altered in HIV positive people. So this usually result in more malignant course, but a higher rate of asymptomatic primary syphilis is also seen. HIV co-infection is associated with multiple and deeper chancres, that is syphilitic chancre, or in case of primary syphilis. 1/4 of HIV infected patients present with concomitant lesions of both primary and secondary diseases. So these patients have predilections for more severe reactions, if you remember Jerisch-Hexamer reaction in syphilis. Another case is a 25 years old male present with ulcers in genital region extending into perianal region, persisting for more than 1 month. Lab investigation results in Leishman stain revealed multinucleated giant cells. Serology for HSV2 is positive. So the question is, what is clinical condition? Obviously it is herpes simplex virus, that is herpes simplex, that is type 2. What WHO clinical stage you will put in this patient? If you remember WHO clinical staging, which we dealt with I think in session 1 or 2, what can be WHO clinical stage for this kind of patient? You can refer to the chart, so that is not a problem if you have it handy. Herpes simplex infection persisting for more than 1 month. So what will be the WHO clinical stage? Deepak says stage 3. Any difference? Okay, stage 2, stage 4. So 2, 3, 4 we have covered, and we all know that stage 1 is asymptomatic. So do you want to refer to the clinical staging chart? You can refer to the clinical staging chart. That is, there is no harm in referring to the chart. I don't expect everyone remembers all stages and clinical events in all stages. Nazia still says stage 2. There is a term here in this presentation, complicated, okay. Persisting for more than 1 month. If you see the chart, what Sumati mentioned is it is stage 4. See, if you see the chart, it is just I think 4th condition in WHO clinical stage 4. So it is one of the stage 4 condition. If it is extending into perianal region and persisting for more than 1 month, it is WHO clinical stage 4. There is, like I mentioned, it is difficult to remember all the infections in clinical staging, especially in stage 4. So the learning from this slide is, please refer to chart whenever you see a patient and you try to do clinical staging. Though, but if it is only minor skin conditions, which will come under stage 3, but if it is a chronic herpes simplex infection extended to perianal region and persisting for more than 1 month, it will fall under WHO clinical stage 4. So syphilis in HIV, although syphilis is uncommon in PLHIV, unusual serologic responses have been observed in both PLHIV who have syphilis. Neurosyphilis should be considered in differential diagnosis wherever the patient presents with symptoms as we saw before in previous slide, that is altered sensorium or any neurological manifestations. PLHIV should be evaluated clinically and serologically for treatment failures at every 6, 9, 12 and 24 months. CSF and retreatment also should be considered for persons whose non-treponemal test titers do not increase 4-fold while 6 to 12 months of therapy. So starting from diagnosis to management to follow-up of the management, it is important whenever a person is diagnosed as syphilis, because you know that from primary it can proceed to secondary and then tertiary syphilis, which is life-threatening sometimes. So broadly, if you see, there are multiple objectives for STI control if you look at it from the public health point of view. So the interruption of transmission of STI is again important objective for control of STI and prevention of complication and sequelae of STI. And then reduce HIV transmission is one of the effects, as we saw, that if you treat HIV infection properly or if you treat STIs properly, the risk of HIV transmission is reduced. The Vanza trial is one of the very famous proven trial which was done in Tanzania, and it was a landmark trial reported in 1995 which demonstrated effectiveness of syndromic management as a STI intervention program for reduction of HIV transmission. That is how now all of us are doing syndromic case management for management of STIs. So these are the components. Cure with treatment, compliance to treatment is important, contact tracing and partner management we do counseling and education, condom promotion and clinical follow-ups also are done. So what are the key primary intervention strategies in our national program, that is NSCP4, to reduce HIV and STI transmission? So you might have heard regarding the multiple strategies which we discussed in brief previously also. First of all, there are STD or HIV STI clinics which have been established as Suraksha Clinic, the scale up of which has been very fast from 2007 to 2013. So there are many STI clinics which are branded as Suraksha clinics, which are there in multiple hospitals which give this syndromic case management. So our duty as a ART center medical officers is again to diagnose STI even if there is asymptomatic. Suppose you come to know if there is a STI syndrome which is present, you should be referring these patients to Suraksha clinics. So that linkage or referrals from ART clinic to STI clinic is very weak. If you see in your own ART center the number of patients you have referred to STI clinics, I don't think many of you will know that information or will have that information, that how many cases you refer to STI clinics. If you are maintaining that record, that is very well and good. First of all, we should make it an habit, especially in new patients, to examine genital area to see if there is any symptom or sign of STIs. At least we need to ask questions regarding STIs, last sexual intercourse, history of ulcer before, lower abdominal pain, and any discharge from urethra or vaginal discharge. Those things need to be asked, which can be done only in if we ask, especially in new patients. So those things need to be done, and at least we need to, if we are not able to do this, suppose, then establish strong linkages with Suraksha clinics of your own hospital if there are there, and most of the facilities will have Suraksha clinics in their hospitals, or most of the facilities will have these STI clinics. If not, at least refer them to the dermatologist or venereologist in your hospital. So this is one of the interventions which is done in the national program. As Sumati mentions, there is another important intervention. It is a condom promotion program. There are, again, this is one program which has been very successful in the mode of intervention. There has been increased, again, a huge distribution of condom or condom promotion activities which have been done. Majorly there are two types of condom promotion which is done through free distribution of condoms and socially marketed condoms at subsidized rates. So free distribution is done in high risk groups, while social marketing distribution, which is subsidized rate of condom distribution, it is done for breech population. Again, there are multiple advantages of condom usage, because of which we promote usage of condom even in ART centers. Our counselor for especially new patient, whenever they identify risk factors as multiple sexuality and all that, at least to those clients or those patients, we should ensure that condom demonstration it happens, especially in private room where there should be a sort of privacy which is maintained. Even in cases of widows and other women who say see, condom promotion is a big umbrella under which many things are covered. So demonstration of condom is again one of the responsibilities of the counselors. I understand because of again huge patient burden, sometimes they are not able to do it. But whenever they identify that a person is at risk of and also has again risky sexual behavior, at least in those cases, condom demonstration and condom promotion should be encouraged, even at ART centers. This again just to see how the condom distribution has happened over a period of time in the national program. Now this is another modality under STI control or HIV control, which is not as a public health intervention in India at least, medical male circumcision, but it is one of the treatment or one of the public health intervention programs in other countries, especially in Africa, which has shown an important way to reduce the spread of HIV transmission there. So according to one of the important studies, medical male circumcision, it provided up to 60% protection against acquiring HIV infection. We can understand this better if we compare this with any vaccine. Even if suppose someone tells us that there is a vaccine for some disease which produces 60% protection, then all of us will encourage that vaccine if there is no other way of protection, natural protection which is available. We do that. So if we compare this intervention with vaccine, as there is no HIV vaccine available at present, this can work very well, especially in those who are at high risk, like I mentioned, multiple sexualities and unsafe sexual behaviors. In them, medical male circumcision is has shown to be very, very effective. 60% is not again a small number. It has again multiple, if you search the web, there you will find multiple evidences on this, and because of which, as I mentioned, it has been important public health intervention program in countries like Africa. If I just quote an example of one of the studies done in more than 3,000 uncircumcised men of young age group, that is 18 to 24, which were randomized to the other 3,000 patients which were circumcised, and in that group also there was a huge reduction in risk of HIV acquisition, and after which it was made sure that it is a major beneficial public health intervention programs which can help in reduction of HIV transmission. Right now also at our personal level we can advocate this medical male circumcision because we know the evidences. Though in India there are multiple reasons because of which it, one thing, because we say that it is a again concentrated epidemic in India, and also there are cultural reservations because of which people don't accept medical male circumcision as a mode of prevention. But if you see the evidences which is not linked to Indian cultural settings, there is a clear-cut evidence that it is not less than any vaccine which we can expect to prevent HIV. Medical male circumcision, because it will protect or it will prevent HIV transmission with as high as 60% reduction. So there are reasons for that, like why foreskin is important, because in male circumcision what is done is the foreskin is removed because it contains more accessible HIV-1 target cells, that is CD4 T cells, macrophages, Langerhans cells, which are closer to epithelial surface and are the first to be infected by HIV. In the mucosal surface of the foreskin also it shows greater infectivity than that of cervical tissue, which is known as primary site of HIV acquisition, and during sexual intercourse whenever there is a release of these sexual fluids, there is a tendency these fluids will get deposited under the foreskin of the penis. So there will be a longer duration of contact with the foreskin, with the penile skin, and also with the mucous membranes. Like we mentioned that one of the risk factors before, that if there is a longer duration of contact with the infected fluids, that also will be one of the factors which increases the risk of transmission of HIV. So this is how the medical male circumcision, it helps in reduction in HIV transmission. Role of STI, we have seen that safe sexual practices and how they reduce the risk of transmission of both HIV and STIs. So here we come to an end of this this slide set. I know that there are again many things which can be discussed under the diseases, especially if we see, or individual infections, which we are not dealing with in this session at least, because we have seen because that has already been discussed by UDA faculty. Please refer to those two sessions which are very elaborative. Even then, in those two sessions this topic cannot be covered because it is such a huge topic. But to solve your quizzes and all, it will be important for you to at least refer to the PPT of those sessions done by the UDA faculty. So we will stop here. As I mentioned that this was the last clinical contact session of this whole series of clinical management of HIV course. I hope all of you have enjoyed this journey of 10 weeks as much as I did, and we all have a WhatsApp group on which we will communicate for some more time from here on also, because the again end product of this course, again the next step is the completion of all the assignments. From my side, I'll send the attendance to the University of Washington. Those who have missed, suppose, a couple of sessions, please do not worry and try to attend, because only 70% of attendance is required. Even if it is less, I'll see how it can be managed, but if there is any scope for that. But at least you, from your side, you need to make sure that all the assignments you solve, and because and also all the homework assignments are solved, including extra credit hours. You need at least 70% of the score for successful completion of the course. The last date of all assignments completion is 22nd of June. So today is 10th of June, still there are 12 days left. Please don't wait for the last day to come, and solve all quizzes, assignments and everything before that date. Once you do that, and once I send the attendance to the University of Washington, so what they will do is they will analyze all the data recorded on the canvas, and they'll see the attendance, and they'll determine who is eligible for certificate receipt. So as I mentioned, that 22nd June is the last date of assignment. So results will be declared after that only. So I will receive the list first of the results. Then I'll inform you all regarding the results of this course. And those who successfully complete the course will receive a certificate from University of Washington, which will be received at ITEC first, ITEC Delhi office. And from Delhi office, we will send certificate to the individual participant through courier. So we will confirm your addresses before we send, so please do not worry on that as well. So before we send the couriers, we will confirm your addresses. So we might require your help in confirmation of addresses at that time. This time we have your addresses, whatever you filled in at the time of registration for this course, but again we will reconfirm before we send the couriers. So is there there can be some delay in certificate receipt, so please bear with me on that as well, and please maintain patience until you receive it. Those who successfully complete the course will definitely receive the certificate that will be ensured by ITEC India. So it might come in the month of July or early August. So whenever it comes, I'll keep you updated. Until that time, we will maintain our WhatsApp group of clinical management of HIV, and after that we can dissolve that group. Just for your information, we have another WhatsApp group where we include all these participants from this course to that national group. That is a national level group named as HIV Physicians of India. Those who are interested to join the group can send me a separate WhatsApp message so that I can add you in that group. Again, the same group rules applies in that group as well. That we do not send any forwards in that group. No greetings. Only that group is maintained for clinical discussions or clinical questions. So if anyone is interested in joining that WhatsApp group named as HIV Physicians of India, where we have X participants of this course, and also there are other participants from the which are national level experts also, who can help us in solving our clinical queries. So those who are interested, please send me a message saying that you are interested in joining national WhatsApp group. I'll do that. For people from Maharashtra, because Maharashtra has a huge number of ART centers, more than 82 ART centers, there is a separate Maharashtra WhatsApp group. If anyone is in this group is from Maharashtra, they can send me a separate message also, so that I can include them in Maharashtra group. Those who are not from this course and are interested in joining those WhatsApp groups can also send me a message. So you can be advocates for that. You can inform the others also if they are interested in joining such a WhatsApp group which offers also clinical question answers. Only clinical question answers. It is not for any forwards, including materials are not forwarded. So it is ensured that others do not get disturbed. So you are most welcome to join this group. Just send me a message that you are interested in joining. I will add you in those groups. So thank you very much for joining this course and being such a participatory group participant. And I look forward to again interact with you all more in such courses in future if they come up. And please be in touch. As I mentioned regarding WhatsApp group, you can send us emails and other things also if you have any clinical queries, or also if suppose you require any clinical resource in form of some article, some journal articles and anything, you can write to us on WhatsApp. You can write to me, Praveen, or any one of us in iTech, so that we are able to help you out in solving your clinical queries. So also we can reach out to clinical. You can directly reach out to the all UW faculties to whom you have listened to during this course. You have their clinical contact details, or you have their contact details on Canvas. You will have access to that Canvas material, but I will suggest that it will be better if you can download that material and save in some folder so that you can refer to whenever you want. So you can directly contact them, or you can contact me or us, and we can get the answers for you through them. So thank you. I think that those are the concluding remarks for this course. Again, as I mentioned in the beginning of this course, courses like this, they help us in accessing to more and more clinical material, but we will not, we will make sure that while working at ART centers, we will adhere to the national guidelines, and we will give our feedbacks to NACO so that important changes can be made in the guidelines, so that the benefit can be gained by all throughout the national program. So please be mindful while implementing the learnings from this course at the ART center, that there is no violation of any NACO or national guidelines while we do clinical practice at ART centers. So again, thank you from iTech. I thank again Praveen for all technical support he provided, and all backhand support at iTech India because for successful completion of all these sessions. So hope to see you again, and hope to interact you again individually in future. So thank you very much. Your again feedback is most welcome. You can send your feedback through emails and also through this poll, which I'll just will be seen on your screen. So thank you and have a good day.